Hello and welcome. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for From Blockage to Better Outcomes, Optimizing GMG Care with FcRn Antagonists. This is case one, personalizing therapy in a complex MuSK-positive patient. This CMEO brief case series is supported by an educational grant from Johnson & Johnson. Today, you'll hear a case-based discussion on selecting and using FcRn antagonists with special attention to MuSK-positive disease. A quick disclosure and fair balance note before we begin. We may reference data or clinical considerations that extend beyond FDA-approved labeling. When that happens, we'll clearly call it out and encourage you to consult the full prescribing information and clinical guidelines when making decisions for individual patients. I'm Dr. Neelam Goyal. I'm a clinical professor in the Division of Neuromuscular Medicine in the Department of Neurology and Neurological Sciences at Stanford University in Palo Alto, California. I'm joined today by my distinguished colleague, Dr. Gil Wolfe. Dr. Wolfe, would you like to introduce yourself?
Thanks, Dr. Goyle. Yeah, I'm Gil Wolfe. I'm a professor of neurology and practice neuromuscular medicine at the University of Buffalo, which is part of the SUNY system. My practice here, as well as my research program, includes a fairly large MG population in Western New York and beyond. I consider programs such as this important given the growing number of treatment options in MG, especially generalized MG. And the growing number of treatment options even includes the FcRn blocker space itself. It merits building a knowledge base in this mechanism of action so that we can best tailor therapies for our MG population.
Wonderful. Before we begin, I want to inform our audience that we will address each other on a first name basis as colleagues. Now, to frame the discussion today, let me start by reviewing our learning objectives for our program. Our first learning objective is to differentiate mechanism of actions, safety, and efficacy profiles of currently approved FcRn antagonists for the treatment of GMG. Our second learning objective includes incorporating strategies to identify patients with GMG who may be appropriate candidates for treatment with FcRn antagonists. Our final learning objective includes utilizing an individualized approach to treatment planning for patients with GMG receiving FcRn antagonists based on the latest data as well as patient preference.
Great, let's meet our first case. Maria is 38 and a MuSK antibody positive generalized MG patient. She's had multiple relapses despite pyridostigmine and chronic corticosteroids. She's tried IVIG with only partial benefit, and she's hesitant about B-cell depletion therapy because of infection concerns. I would point out that pyridostigmine and other acetylcholinesterase inhibitors, as well as intravenous gamma globulin therapies, often don't produce much benefit in MuSK-MG. That's been seen in several series. In fact, I was just reviewing some data on acetylcholinesterase inhibitors that touched on that very fact with MuSK-MG, where they can even suffer more side effects than you would see in other populations of MG patients when you actually administer an agent such as pyridostigmine. On top of that, Maria is paying the classic steroid tax, weight gain, insomnia, and osteopenia. Her question is pretty straightforward and very real world. Are there newer therapies that can give me longer lasting control without all these side effects?
Yes, thank you, Dr. Wolf. Exactly. Maria is the typical type of patient that forces us to think beyond what works and really towards what fits and what is going to improve the overall picture, including reducing harm and toxicity over time. Before we talk options, let's zoom out for 30 seconds or so on why new approaches matter in GMG. Gil, can you comment on this?
Sure, Neelam. So even with pyridostigmine, corticosteroids, and conventional immunosuppressants, a meaningful minority, on the order of about 10, 20% or so in published estimates, don't achieve adequate control or can't tolerate that therapy. And if you add in the burden of repeated rescue treatments like intravenous gamma globulin or plasma exchange and the long-term complications of steroids, you really are dealing with a big, big burden for patients. Look, we see sleep disturbance, mood changes, and dermatological complications, in addition to the well known weight gain, metabolic disturbance, hyperglycemia, and bone loss when we give patients corticosteroids. And it really doesn't even have to take that much exposure over time to start seeing some of these problems, such as the sleep changes, for instance.
Gil, walk us through FcRn. What is it and why blocking it helps in antibody-mediated disease like myasthenia gravis?
So the FcRn stands for the neonatal Fc receptor. The day job of the neonatal Fc receptor is to recycle IgG, protecting it from degradation in the lysosome and extending its half-life to about 3 weeks. That's at least a couple of weeks longer than the half-life for IgM, IgA, or IgE.
Wonderful. Thank you for that review. Now let's anchor to what's actually FDA approved for generalized myasthenia gravis and how the regimens differ. Gil, can you review this for us?
Sure. So right now, and this just changed quite recently in the middle of 2025, we're now talking about three FcRn antagonists with indications in generalized myasthenia gravis. But the labeling difference does matter a lot in patients such as Maria. Efgartigimod is approved for acetylcholine receptor antibody positive GMG in adults and is given in cyclical dosing. So the typical dosing for it, the way it was approved, is 4 weekly infusions. They can be done intravenously, they can be done subcutaneously as well. And then there can be a varying amount of time between the individual cycles. I'll also mention that the second drug approved in this class also was approved with a cyclical type dosing. Here for rozanolixizumab, it is 6 weekly subcutaneous infusions. Finally, there was an approval of nipocalimab in the middle of last year. That actually is delivered intravenously every 2 weeks. So it's a set dosing every 2 weeks for patients. They all share that same mechanism of action, however, of preventing the recycling of IgG. And remember, that will include disease causing IgG, such as antibodies to MuSK, as in this case, or antibodies to the acetylcholine receptor. I would mention that the labeling is likely to change in the near future for some of these agents, so that there'll be refinements in the schedule where it won't quite be so based on a cyclical delivery system and potentially allow for a more stable course. So for Maria, because she's MuSK positive, the labeled neonatal Fc receptor blockers for that subpopulation of MG are rozanolixizumab and nipocalimab. And then we can tailor the route and dosing strategy to her goals and logistics.
Thank you for reviewing that, but let's get into a little bit more details. Gil, can you review what the pivotal trials on these FcRns tell us about efficacy?
Certainly. So the endpoints differ to some degree, although they were all based on the MG-ADL in some fashion. But the headline here is that each of these agents demonstrated statistically significant improvement versus placebo on the MG-ADL with supportive improvement on the QMG as well. So both subjective and objective measures that are commonly used in myasthenia gravis. And several other secondary outcome measures also solidify the efficacy of these agents in generalized MG. It's important to realize these are not head-to-head trials. There were differences in the recruited population, dosing approaches, and endpoint timing that makes it really tricky to try to do any cross-study comparisons. Any of those types of comparisons you really need to look at those with a grain of salt, okay? So, we can't really declare a winner, say, by a decimal point here or there. If you want a refresher on what these scores mean clinically, we have a quick guide here so you can take a look at the MG-ADL and the QMG.
That was a wonderful review. And just like we talked about with the steroids, safety is very important, especially as we think about new agents. So, regarding safety, what should clinicians be ready to counsel on and monitor?
So, across the class, the key conceptual safety point is that when we lower IgG with these agents, which they do very effectively and quickly, and we're talking 60 to 70 to 75% reductions in IgG over a period of just a couple of weeks, it's kind of not surprising that we increase infection risk. So we need to monitor for infections during treatment and counsel patients accordingly. The most common infection issues, which tended to be mild to moderate in the trials, really mostly mild, they occurred somewhere between 5 and 15% of patients across the studies, and they were mostly UTIs and upper respiratory infections. There were some COVID cases. Several of these trials were conducted during the pandemic, but it's something to be aware of and to monitor for. But one thing I want to reiterate is, for the most part, these were mild and moderate type of infection AEs. We'll drop a short checklist here you can use in your clinic. For a larger view of the adverse event profile of these agents, we've dropped a short checklist here that you can use in your clinic.
That was a great review. So let's pause now for a quick audience check. So for Maria, so as we recall, she's a young woman. She has MuSK positive GMG. She's not interested in a B cell depleter, which we would consider almost first line for her, and has had partial response to IVIG, steroid-sparing agents, and steroids with ongoing toxicity. And the question is, which FcRn antagonist characteristics is most relevant for her? And Dr. Gale, can you review this for us?
Sure. So we're going with an FcRn antagonist. What's most relevant in her case? Well, let's look at the answers. One that's approved only for receptor antibody positive GMG, that would not be appropriate here. The next item B, an FcRn antagonist indicated for MuSK MG could be considered. All three FcRn antagonists are equally effective, interchangeable for MuSK disease. Well, that's not true. Efgartigimod specifically is not actually approved in MuSK myasthenia gravis. And the D was FcRn antagonist should only be considered after failure of B-cell depletion therapy. There is no requirement with these agents that they fail a specific agent, at least the way that they're labeled, before they're actually administered to a patient. So that's not correct. E, I'm not sure. Well, I hope people are mostly sure. She is a MuSK MG patient. She's a woman. Most MuSK MG patients are women, by the way. So I think the correct answer here should be B. What do you think?
Yeah, thank you for reviewing that. And I think these questions and answers really highlight two things. One, because she's MuSK positive, we should only consider the FcRn agents that are approved for MuSK positive MG, which would include rosatalixizumab and nipocalimab. And three, like you mentioned, patients don't need to fail a B-cell depleter or another agent before an FcRn antagonist can be considered for their disease. Now let's tackle the steroid problem head on, because Maria's complications are the reason many of us reach for targeted therapies. As we've all experienced, even at low doses for short periods, steroids come with real common burdens, weight gain and metabolic effects, insomnia, osteoporosis, and long-term risks like infection and eye complications. There are multiple studies that look both at short-term and long-term complications with steroid treatment, and some in particularly with myasthenia gravis. Also, we know that newer agents can reduce the dependence on steroids. We've seen this with long-term studies with both efgartigimod as well as data in other agents as well. There are also multiple different ways to taper medications, and there are some best practices. Here, we will provide a link for practical considerations and best practices when considering tapering steroids. Let's translate this to Maria. Her steroid-related issues include weight gain, insomnia, and osteopenia. This makes steroid minimization a clinical priority and not just a nice to have when thinking about her care. So as we choose an FcRn strategy, we're not just aiming for MG-ADL improvement, we're hoping both for MG-ADL improvement, but also to reduce her dependence on steroids and limit both short and long-term toxicity of her current steroids. Here we have two dosing philosophies that you hear about when patients ask about, and we discuss treatment options with FcRn inhibitors. So our first-in-class FcRn inhibitor, efgartigimod, which is only approved for AChR antibody-positive disease in adults with GMG, was given in a cyclical fashion. And this was discussed by Dr. Wolf earlier. Rozanolixizumab, which was our second in line, similarly is being given in a cyclic fashion. However, our third-in-class nipocalimab is actually being given in a continuous fashion, and there are both advantages and disadvantages to both of these strategies. For those medications that are given in a cyclical fashion, perhaps some advantages include that patients need fewer visits during maintenance, and there is some IgG recovery between cycles that may limit some side effects, including infections. However, one big downside of giving these agents in a cyclical fashion is that for some of our patients, they get return of symptoms during that off period, which can be very distressing for our patients. On the other hand, for nipocalimab, which is given in a consistent fashion, some of the advantages include that there is a consistent dosing schedule, there's sustained IgG suppression, and this predictable scheduling and sustained IgG suppression limits this recurrence of symptoms during the off period. However, on the other side, patients require more frequent visits, and this sustained IgG suppression may lead to increased risk of infections. There are also differences in the route of administration for these three agents. Efgartigimod and nipocalimab are both IV formulations, which means they require IV access, cannot be self-administered, but can be given both in the hospital setting, outpatient infusion center, or at home with an infusion company. Efgartigimod has a subcutaneous formulation, and rozanolixizumab is also subcutaneous. Both of these agents require a healthcare professional to administer. Rosanex requires a specialized infusion pump. More recently, efgartigimod has been available in a pre-filled syringe, with sometimes which we can get approved for MG, and it can be available for self-administration. The subcutaneous formulations are particularly helpful for patients that are difficult IV access and can help us avoid the need for a port. Here is the shared decision checklist that can be used at the bedside. So we want to know when thinking about starting the right FcRn antagonist for a patient, we want to know their antibody status, because then we want to know what agents are approved for their subset of disease. We want to understand their stability needs. Do they have frequent fluctuations? Are we concerned about recurrence of disease during the off cycle? How distressing would that be for the patient? Would they prefer something continuous because they value this lack of flares or recurrence of disease? Or would they value having less infusions and be okay with their symptoms coming back? As was discussed previously, the safety considerations for all of the agents are relatively similar, where we see higher incidence of mild to moderate infections, headaches. A few of the agents may also have increased risk of peripheral edema, which tends to improve over time, as well as some muscle cramps. And so, really, we want to think about all of these different things as we consider what is the correct FcRn antagonist for our patients. You'll see a patient-friendly shared decision-making tool that's linked here, which can help you in this process. So for Maria, route preferences should be discussed explicitly. Her fatigue and schedule may influence whether she leans towards subcutaneous convenience or an IV supervised setting. Because she has MuSK antibody positive disease, the two agents that we would discuss for her include rozanolixizumab, which is available subcutaneously provided by a healthcare professional, given in a cyclical dosing of 6 weeks on, 4 weeks off, or nipocalimab, which is IV administered with consistent every 2 week dosing. And of course, her steroid complication makes steroid sparing a priority. Discussion should include her preferences for dosing frequency, route, and tolerance for headaches, which may be higher with rozanolixizumab.
One thing I'll interject is you can actually have a strategy of pre-treating the expectation. If headache is likely in a patient who has a long history, for instance, of headache problems such as migraines, you can plan for it up front with hydration, timing, rescue medications as appropriate, so it doesn't become the reason that the patient would abandon a therapy that otherwise would be quite effective in treating the underlying myasthenia gravis. You can find out, all right, does acetaminophen work best afterwards, or perhaps another type of nonsteroidal anti-inflammatory drug as far as managing the headache and things like that.
That's a great point, Gail. Absolutely. When we think about side effects, it's important for us to think about what we can do preemptively to avoid such things. All right, so let's pause here. And before we show the illustrative resolution of this case, let's walk through how you'd build the plan using the framework we've just discussed. What would you choose? What would you monitor? And what would change your mind? So, Gail, can you just walk us through? We've sort of done a background of what an FcR antagonist is, the different options, the different things to consider in shared decision making. If you were sitting across from Maria, which I'm sure you have at many times, how would you approach this case? What would be your thought process?
So, given her treatment history and the fact that she really doesn't want to opt for a B cell depleting therapy, which we have used quite successfully in MuSK MG, well, I think the obvious choice with that background is to consider an FcRn antagonist. And as far as the choice, what may make you lean one way or another? If she's had a very brittle disease course with a lot of fluctuations up and down, perhaps a more set schedule will be the best approach. On the other hand, if intravenous access is difficult, and she's younger, so that's not likely, but let's say she was quite a bit older and her veins are not that good, then perhaps one of the subcutaneous infusion options would be the best choice. Again, the efficacy overall between these different agents are all sort of in the same field. Let's say right field on a baseball stadium. They're all in that same general area. Okay. Other things to consider, how would you incorporate steroid sparing and monitoring in the first 4 to 8 weeks? All right, so look, these agents can work really quite quickly. We can see reductions in MG-ADL and QMG within a week or two, definitely within 3 to 4 weeks, is quite typical. And so, with that improved disease status and the fact that she's had so many steroid side effects, I would definitely be considering a reduction in her steroid dosing at that time point, not waiting 2 or 3 months, but to consider it quite early. And again, we can taper, at a relatively slow but faster rate than we would with a non-steroid immunosuppressant agent, where we only taper about every year. At least that's my practice. But on an every 2 week basis, perhaps dropping by 5 to 10 milligrams with each of those steps until we get to doses, say, of 15 or 20 milligrams. And then I might even slow the tapering schedule down to just 2.5 milligram steps. Neelam, I'll let you take on that last bullet point there. What patient preferences, logistics could change your plan here?
Yeah, absolutely. So I absolutely agree. I think next step for her is an FcR antagonist. In regards to the two agents that we're thinking about, the subcutaneous and intravenous, because rozanolixizumab is not available currently in a self-administration, I think the logistics would be quite similar for the two. One would require continuous infusion, so we would have to just schedule something either at home with nursing care or at an infusion center with nursing care. But she would have that consistent schedule. And then once she was doing better, responding, we could start tapering the steroids. For rozanolixizumab, this would be cyclic. So the benefit would be that she would have a period off if she wanted to travel. However, during that period, her symptoms could come back. So there could be more modification and modulation in terms of those cycles, which may or may not be to her benefit. So I think definitely many things to consider as we think about what is the right FcRn antagonist for Maria. So, in this illustrative resolution, Maria starts an FcRn antagonist that is selected through shared decision making. She is MuSK positive and she has a preference for predictable, scheduled, and supervised administration. The potential risk of return of symptoms is worrisome and bothersome for her, and so she prefers this consistent dosing. After she's initiated on her FcRn antagonist, she notes improvement of symptoms and positively her symptoms remain stable during follow-up. She has fewer fluctuations and she has no need for rescue therapy. Because she is doing well, we are able to reduce her steroid dose over time, and this leads to lower side effects, which of course has a wonderful positive impact on her quality of life. Her tolerability is manageable. She has transient edema and headache, which does improve over time. She has practical fit. Her practical fit improves adherence. This predictable schedule aligns with her routine, and she has reduced missed visits. So, in terms of key takeaway, in MuSK positive GMG, outcomes depend not only on pharmacology, but on matching route, dosing schedule, monitoring needs, and patient logistics/preferences to support sustained control and steroid minimization. So, let's close with SMART goals, concrete actions that you can implement. So, let's hope that within 1 week, for every GMG visit, you document the antibody status of the patient, the MG-ADL, if they're on steroids or nonsteroidals, any recent need for IVIG or plasma exchange to flag candidates for FcRn therapy. Within the next 30 days, you start shared decision making in at least a quarter of your patients, confirming eligibility, align dosing strategy and route with patient priorities, and review key safety and monitoring. Within 6 weeks of start or change of therapy, recheck MG-ADL and record any exacerbation rescue therapy to guide continuation and dosing plan. Within 3 months, for your stable patients on prednisone, document a taper plan, track dose reduction, and capture one or more steroid burden markers, which may include sleep, metabolic disorder, mood, energy, as well as skin manifestations. And ongoing, provide infection risk counseling, document adverse events and management, and verify prescription information-based administration and retreatment and intervals. For additional tools and patient-facing resources, visit the CME Outfitters Neuropsychiatry Hub. It's a curated set of education and practical resources that can support both clinicians and patients between visits. This concludes part one. In part two, we'll take on a different challenge, optimizing dosing and scheduling in a partial responder, how to interpret waning response, adjust intervals, and continue to reduce steroids while maintaining control. We would like to thank CME Outfitters for their partnership in creating this education, and we are grateful to Johnson & Johnson for their independent medical education grant that makes this series possible. To receive credit for this activity, please complete the post-test and evaluation. We appreciate your feedback and want to hear from you. Tell us what you liked, how we can improve, and what additional topics you would like us to address. Gail, thank you so much for sharing your expertise and experience today.
Thank you, Neelam, for including me, and thanks to everyone for joining us on this program.
Yes, thank you to our audience. We look forward to seeing the ways you can translate this into